Good afternoon. Welcome to the Daily Brief on Metro Milwaukee's Health and the Economy, brought to you by the Medical College of Wisconsin and the Metropolitan Milwaukee Association of Commerce. I'm Tim Sheehy, president of the MMAC, joined by my co-host, Dr. John Raymond, president of the Medical College. Each day at 3:30, we deliver a 19-minute fact-filled update on the health and economic impact of COVID-19. This webcast is powered by Aurora WDC. Our special guest today is Chris Miskell, President and CEO of Versity, which includes the Blood Center of Wisconsin. And so I'm going to turn it over to Dr. Raymond, and just a warning to our viewers, by the time you're done with these two guests, you're going to have a great new level of medical vocabulary for your crossword puzzles. Dr. Raymond?
Thanks, Tim, and it's an honor to be here today with Chris Miskell, so welcome, Chris, and good afternoon, everyone. The first slide summarizes various indicators of COVID-19, and I'll run through these very quickly for you, and then move on to an update about 3 potential therapies for COVID-19. The first indicator is doubling times, and these have improved to 13 days in Wisconsin and 16.5 days in Milwaukee, so that's great progress. Daily growth rates have stabilized at 4.5% in Wisconsin and 3.1% in Milwaukee, and the percentage of positive tests are 6.9% in Wisconsin and 12% in Milwaukee. And as you recall from previous afternoon briefs, this is a new Badger bounce back metric. We're also tracking the number of positive tests in Wisconsin, which were 334 today, and Milwaukee at 125. To summarize the testing capacity, it is increasing in Wisconsin and in Milwaukee, and I'll show you that on the next slide. ICU and ventilator capacity remain adequate, both in Wisconsin and in Milwaukee, and the personal protective equipment trends are stable. Next slide, please. This slide shows that the statewide capacity to test for COVID-19 infections, as shown by the blue line, has increased significantly over the last 2 weeks and is approaching the goal of at least 85,000 tests per week. As you can see, our capacity is over 10,000 tests per day. Similarly, testing has increased significantly in Milwaukee, and soon I expect that we'll be able to roll out serological testing all across Wisconsin and Milwaukee. Next slide, please. Now I'd like to update you about 3 potential COVID-19 drug treatments. I'll start with a drug that's been hyped despite a relatively low-key approach by the research team. Famotidine, or Pepcid, is an over-the-counter H2 blocker used for gastroesophageal reflux. Surprisingly, this drug is being tested by Northwell Health in New York, where COVID-19 patients are being given IV famotidine at 9 times the heartburn dose. The idea to test in the US was Dr. Michael Callahan's, who observed the drug being used as a treatment in Wuhan, China. The proposed mechanism is to block a COVID-19 enzyme called papain-like protease, which is needed for the virus to replicate or to reproduce. The results of the first clinical trials of the drug are expected to be released in the coming weeks, but because this has received significant social media attention, I wanted to bring it to your attention here. Next slide, please. On this slide, I'd like to review the emerging positive breaking news from yesterday about remdesivir. This is a repurposed, failed Ebola drug that inhibits viral replication. In other words, it stops the virus from reproducing. One study released yesterday showed a 31% improvement in the length of hospital stay of COVID-19 patients, with an improvement from 15 days to 11 days. And there was a trend toward lower death rates of 11% versus 8%. Now, another study on this drug released earlier this week showed equivalent effects of 5 and 10-day treatments. And this is important because if the 5-day treatment is as effective as the 10-day treatment, because this is not a drug that has a high production capacity, we can use it on twice as many patients. And although further studies are necessary, the usually cautious Dr. Anthony Fauci yesterday referred to these studies as, quote, quite good news, end quote. Now, I'd like to emphasize that this drug is not a cure, but it may become the standard of care in the United States. Next slide, please. The third drug I'd like to discuss is favipiravir, which is a repurposed influenza drug manufactured by Fujifilm of Japan, and it was designated as the standard of care 2 days ago by Japanese Prime Minister Abe. It's also widely used in Turkey. And the original basis for using this drug was a Chinese study of 340 patients that showed that treatment resulted in a faster clearing of COVID-19, 4 days versus 11 days, and more improvement in chest X-ray findings over the course of the study, 91% versus 62% of the patients. This medication is thought to be most useful for early treatment and might not be effective for the sickest patients. And a new trial of the drug was just started in India. This is a promising drug, but it might not provide much additional benefit compared to remdesivir because the mechanism of action is supposed to be the same. Next slide, please. Now, this final slide is from our neighboring state of Illinois, and it shows that the iconic Lions of the Art Institute of Chicago were recruited this morning to demonstrate the importance of wearing cloth face coverings in public. This highlights the need for continuing diligence and social distancing as we move ahead with the reopening of our economy. Thanks again to all in our audience for your interest, and now I'll turn it back over to Tim.
Thanks, Dr. Raymond. It sounds like the harder it is to pronounce the drug, the better it is at curing COVID-19. But seriously, the question for you I have is, it looks like there won't be kind of like one miracle drug. It looks like there are going to be a series of solutions to helping us move through the next normal.
Yeah, I think that's true, Tim. We'd all like to have a miracle drug, but viruses are notoriously difficult to treat. And to have even small improvement in a subset of patients like we're seeing with remdesivir is really good news.
Chris, let's pivot to you and talk a little bit about first kind of who Versity is, what the Blood Center of Wisconsin does. I think some of us have a high level view of that. And then you're going to talk a little bit about plasma treatments for COVID-19 patients.
Yeah, thanks, Tim. I want to thank the MMAC for the opportunity to speak. Also, thanks to MCW, wonderful campus partners for us on the academic medical campus. I think that this resource that you've set up is pretty incredible. So Versity at a glance, if we click to the next slide, we really do all things blood. And from a service line perspective, we've got 5 service lines, whether it's blood services, essentially collecting blood, making it safe, and then getting it out to our hospitals so that they can serve patients. We do very sophisticated esoteric lab testing. We have a research institute with world-leading investigators that sits in Wauwatosa. We have physicians in hematology that do clinical care and also do clinical research. And then we also have the organ and tissue procurement for the region to make sure that for folks that are on waiting lists, we can get organs to save their lives. 4th largest independent blood center in the United States, nonprofit 501c3, and you see some of the stats there around revenue and employees, but a sizable operation. What differentiates us though from other blood centers is our emphasis in science and medicine. So if you click to the next slide, what I would share is that COVID-19 has caused us to go into some pretty severe planning scenarios to make sure that we can be there when our hospital customers need us. The one thing I know about these scenarios is that none of them are exactly right. They never are, but we've tried to create the bands around what we're seeing. We've essentially seen about a 30% drop in blood utilization. Lots of those elective surgeries have been pushed out. That has a direct impact on both our top line, but also how we think about workforce planning. And so because of that, we've needed to rethink how much blood we're collecting, what that means for the people that are in those roles, and then how we monitor the future to scale back up so that when the surgeries return, we can support them. You see some of the things that we're tracking around the social distancing duration, availability of PPE, when we might have a diagnostic, as well as what could happen in the fall. And we've tried to create some error bars so that we can, we know it'll be somewhere between these scenarios to make sure that we can plan. The one plug I would put in is that the social distancing requirements will hurt a little bit of our capacity on our blood drives. And some of the people impacts, if we have folks that go out for various reasons because of COVID-19, then that could put some pressure on the system as we move into the summer. So I would ask those that have been loyal donors to consider either donating or running drives as we get into the tough summer months. If we move to the next slide, another place where we've been able to play is with convalescent plasma. You may have seen this in the media. We're really excited about being able to play our role to help patients. So just to recap here, convalescent plasma, reason to believe is that folks that have recovered from the virus have these super antibodies that potentially could help others that are in a weakened state. Once someone has recovered, we bring them in and collect those units. The reason to believe here is that in prior outbreaks of things like H1N1, influenza, the concept conceptually has worked. Obviously, this is considered experiential therapy, though. But you see the criteria here for how we collect. Someone has to have a confirmed diagnosis by a physician or a lab test, and then they have to be either symptom-free for a period of time, or they have to be symptom-free for a shorter period of time, but with a confirmed negative viral test. The demand for convalescent plasma is much higher than the inventory that we have today, but we're working hard to get the word out so that those that have recovered from the virus can potentially donate and allow us to collect. As of 6 a.m. this morning, we've collected 362 products from 118 donations. A convalescent plasma, a donor can donate weekly up to 4 times. So for those that have come on board, we're working to get them to come back up to 4 times to help us out. If you know anyone, if you'd like to learn more or know someone that may be a candidate, we've put the link here into the website for you to go to. Next slide. And then the last thing I just wanted to talk about is a creative opportunity that we've got that's coming to fruition. Last summer, we bought a company in Austin, Texas, that's a central lab that offers very highly customized services, basically in the clinical trial space, which is a space that we're in at Versity as well. And it was complementary to some of the things that we do. So last summer, we purchased this organization, and right now they are right in the midst down in Austin of supporting a diagnostic reagent manufacturer with a huge need. Basically, this diagnostic reagent manufacturer has the secret sauce, the recipe for a molecular transport media that's designed to inactivate viruses that are being tested. So imagine that an employer decides they want to test their employee base to see if they've got the virus or not. What this reagent manufacturer would do is you'd swab the nose, essentially break the stick. That stick goes in this transport media that then goes off to a lab that can assess whether or not that test is positive or negative. But when you're moving that sample, you need the transport media to make sure you inactivate the virus, but you can still test it. So our company is subcontracted with the reagent manufacturer to basically manufacture the product and support the logistics associated with that molecular testing. But the opportunity was so large that actually we're doing that not only in Austin, we've been able to bring that up into the Midwest, starting with our Illinois location. So the nice part about that is we had some folks that were displaced that had hour reductions because of COVID-19. We're able to get hours and workload back for some of those folks. Next slide. So I'll just close with this on the next slide. I think that your mission, vision, values really show through in times of crisis. They're kind of these moments that are crucibles of innovation and kind of say a lot about your organization. I've been pretty inspired to watch our team come together and continue to support and serve the community. Thanks, Tim, for the time.
Yeah, thank you very much, Chris. And every time I hear you go through what you do, I realize that blood collection is kind of just the tip of the iceberg, and we're really blessed to have a kind of asset like Versity in the community. So thank you for your leadership. I'm going to bring Dr. Raymond back on, and then we're going to go to questions from our viewers for both of you.
Yeah, the first question is for Chris. Chris, why is there a 4-time limit on an individual being able to donate plasma? Do the antibodies reduce in effectiveness after that?
You know, that's my hypothesis. So Dr. Raymond may know better than me. I know that the team's guidance that they've given folks is that when you get someone back and those antibodies kind of fire up, you bring them in, they donate, they have to wait a week, then they can come back. So my hypothesis is that, yeah, after a month, there's probably something with the strength of the antibody that leads them to believe that the utility falls away.
Another question for both of you potentially, since we don't yet know everything we want to know about the immunity of somebody who's recovered from COVID-19, how does that affect how optimistic we are about the effectiveness of convalescent plasma treatments?
I'll start and then I'll let the doctor back clean up. So again, this one's an experiential therapy. There's reason to believe it works. Anecdotally, what we do know is that whenever you're doing something like this, you want to think about safety first. So we know that the toxicity related to this is extremely limited. So it's pretty safe to administer. From an efficacy standpoint, it's anecdotal. Anecdotally, we're hearing lots of stories that people feel like patients that get the transfusion are getting better, but again, it's anecdotal evidence and it's hard to know if they would have gotten better with or without the therapy. The gut feel from many though is that there's an impact.
Yeah, I think that's fair, Chris. And everyone needs to know this type of treatment's been around since the late 1800s, and it's been used successfully in many other infectious diseases.
Another question for Dr. Raymond. With the increase in testing, can and will the general public who aren't necessarily experiencing symptoms, will they start to get tested either for current infections or serological testing?
Yeah, I think that's a realistic goal, and hopefully we'll be there within the next month.
Another question for Dr. Raymond. What's the forecast for returning to quote unquote normal medical procedures such as elective surgeries and even visiting your primary care?
Well, I want to start by saying that it's safe to have those done right now, and that I believe consistent with the loosening up of regulations allowed through the Safer at Home, and as recommended by the MMAC and other organizations, the health systems are going to be able to start to do some non-elective or some elective procedures soon. And we want to make sure everybody knows it's safe to go to your primary care physician right now, and you should be making appointments for your routine regular care.
Chris, we had a question about how you find and recruit your convalescent donors.
Yeah, it's a great question. We get help from the hospitals. What tends to happen is the hospitals have so back to the equation of we have less inventory than the demand right now. So the hospitals are very interested in helping us out. Hospitals tend to know where those patients are, and they're directing them to us. That's the way it's been working the best, is the hospitals know where the patients are, and they're kind of flagging that as they're starting to recover that they could help someone else. We've done a few pushes. We've reached out to some government officials in the spots where we operate to try to get air cover support. But word of mouth, grassroots, anything you can do to direct people to us, we greatly appreciate as well.
Another somewhat related questions. Do we know yet if an asymptomatic person can become a convalescent plasma donor?
So right now, the way, at least the protocol that we're operating under, they would not, because they would have to, well, let me say it a different way. The criteria, the way that we're including people right now is typically they've got to have that lab test that confirms that they indeed had the virus. So that's the first step. And so if they're asymptomatic, then I imagine that confirmation process gets more difficult. What we're finding is lots of people get into the front end of the funnel wanting to help, but then there's something as they work through the inclusion criteria that usually will knock folks out. And many times it's that 28-day period that you have to wait before you can, so that you've cleared it and you can get into to donate.
Then shifting gears for one last question, we actually had a question for Tim about the future of retail shopping and whether the current environment has sort of accelerated some trends we've seen toward online shopping away from traditional retailers.
Well, I think it's true for retail and it's true for most businesses now. They've had a really long period of time to evaluate how they do business, how they interact with their customers, and how they interact with their employees. So some of these are going to be temporary, but some, as we're talking about in the retail sector, are going to change. As people have become more wed to ordering online, I think it's really grown the number of folks who have utilized that, and that trend and that habit is likely not to recede back to its current levels. So I think in coming weeks, we're going to be talking about, different industries and how this experience has changed them temporarily and what these trends may be on a longer term basis.
Great. Thank you to all three of you, and thanks to everybody who asked a question today.
Chris, Dr. Raymond, thank you again for joining us. Please tune in tomorrow at 3:30. We do not have a guest So it's going to be 19 minutes of Dr. Raymond, and I'm going to come up with the top 10 most asked questions about COVID, and we'll get our response from Dr. Raymond, and you can ask your own questions. So again, have a safe rest of your afternoon. Thanks for joining us.
Thanks, Chris. Thanks, Tim.
Yeah, good to see you, John. Good to see you, Tim.